Good morning. I'm Ron Schenkman, the publisher of Payers and Providers. I want to welcome you to today's webinar event, Building the Exchanges, Seeking the Right Roadmap, with Kevin Counihan, President of Choice Administrators Exchange Solutions, and Mark E. Lutz, a member of the law firm Epstein Becker Green. Now, I'm going to turn over the webinar to our presenters. Kevin, please begin.
Good morning, everybody. Thanks so much for participating. A key goal of this webinar is to provide you with some background information on the experiences and lessons learned from exchanges in the past, particularly building off of my prior experience as Chief Marketing Officer at the Massachusetts Health Insurance Connector Authority, and also talk a little bit about some of the key ways to make exchanges successful. There's an opportunity, as you know, to provide questions, and we look forward to providing comprehensive answers to those. Let me begin first with just a quick overview on a definition of exchanges, because it's a word that's used quite a bit these days, particularly with those that follow federal law and the political debates. But in essence, an exchange is a couple of things. First, it is an organized marketplace for individuals and small businesses to shop for health insurance. And in this way, it's fundamentally trying to bring the type of consumer shopping experience and transparency that exists in buying other consumer goods, and the kinds of things that, as consumers, we take for granted in buying other goods. Exchanges also work to promote the purchasing of health insurance based on quality and value. That's done in part through the transparency that I spoke to earlier. I talked about making cost coverage, the provider networks, the physicians and specialists that are in the health plan network, and also the services, whether they be call center services, other value-added services provided by a health plan, making those transparent to the consumer. Next, it's to provide a consistent format with compliance with the new consumer protections in the Affordable Care Act, otherwise known as Obamacare. But the Affordable Care Act has some helpful consumer protections. Just to give you a few that were changes, is the elimination of pre-existing conditions, providing guaranteed issue of health insurance, where in many states medical statements are required at present. All those kinds of things have been changed with the enactment of the Affordable Care Act. And finally, to provide the user with an easy and simple experience in shopping for health insurance. This is fundamentally important because I think, as many of us know, consumers find purchasing health insurance to be expensive, complicated, frustrating, and frankly, they trust very few entities in the whole purchasing chain. Whether this is health plans, brokers, consumers, and there's data to support this, consumers often think that somewhere along the line they're being taken advantage of. They're not sure by whom or where, but somewhere that this game is rigged. So ideally, when exchanges work properly, the increased transparency and the focus on a easier and simpler purchasing experience works very favorably to ameliorate much of those concerns. As I talked about before, the enactment of the Affordable Care Act last year provided a number of different coverage options. One is through the offering of something known as essential health benefits. And basically, that's sort of a fancy term for a minimum standard of health insurance coverage. As many of you may well be aware, there have been many instances where consumers have purchased health insurance plans with the expectation that they covered a range of services, where it turns out that, in fact, they do not cover those services, and this has caused financial hardship for the consumer. So one of the consumer protections in the Affordable Care Act, or ACA, is is requiring that health plans offer a defined set of benefits known as essential health benefits. Now, to be honest, this range of benefits has yet to be fully defined. The Institute of Medicine issued a extensive, about 300-page recommendation of what the EHB would look like about 2 weeks ago, and it will be up to federal regulators and policymakers to take those recommendations into consideration. But fundamentally, it gets to the point of requiring qualified health plans offered through the state exchanges to offer a minimum standard of essential benefits. This, by the way, came from one of the features of the health reform in Massachusetts, where we had a provision known as minimum creditable coverage, and basically it's the same thing. The second is that exchanges have the option to offer broad or narrow coverage choice options. One of the ways that the Affordable Care Act works to make purchasing a little bit simpler and easier for individuals and small businesses is to align those benefits, those essential health benefits, into 4 metal categories: platinum, gold, silver, and bronze. And just as a minor factoid for you, the genesis of this also came from Massachusetts, where Massachusetts offered tiers on gold, silver, and bronze basis. This actually came from my wife, by the way, because when I was first hired back in '06 to come up with a number of things, including names for these tiers, I was driving my wife crazy at night, giving her ideas, and she finally told me to stop and just name it after the Olympics. So that's actually how the gold, silver, and bronze came about, and that's her contribution to federal law. Exchanges tend to be most effective when the price for the health insurance premiums are the same both inside and outside of the exchange. The reason why is fairly obvious. For example, if it costs more money to buy the same plan of benefits inside the exchange, it's certainly going to drive more purchasing behavior to go directly to the insurance carriers or to some other sources outside the exchange. So in a way, it dilutes some of the value proposition of the exchange when there is price differentiation. It's unclear. There is inconsistency, frankly, as to how the states are approaching this. Many states are looking at providing the same premium inside and outside. Some states are actually looking to make the premium a little bit more expensive for that coverage outside the exchange. Finally, it gets to this issue of standardization of benefits. Consumers, one of the things consumers have opined on is the confusion they have in terms of understanding health insurance coverage and plans of benefits. One of the things that some states are considering to address that concern is through having all the insurance companies provide the same designs of benefit plan coverage uniformly across the exchange by metal tier. So, for example, there could be that all gold plan designs would have one set of benefits. It could be that a state would have, say, a silver high range, a silver medium, and a silver low, but within each of those, that matrix of coverage, the benefits would all be the same. The idea behind this is, again, to enhance and improve the ease of the consumer experience by standardizing coverage so that individuals can focus more on not just differences in coverage, but also areas of importance to them, such as provider network, the customer service of the health plan, and other value-added services. So this is not all states doing this. It's something that we introduced in Massachusetts in 2008 as a result of consumer research, and there are some other large states considering the same. Other states are looking at this on a come what can, which is that any willing insurer that's licensed by the Division of Insurance could put up any plan design it chooses to, and consumers would thus have the broadest choice possible. A good example of that would be Utah. So, finally, let me just do a little comparison between Massachusetts and Utah, because these are the two existing state exchanges in the country right now, and they represent different ways to in essence, form an exchange. So in Massachusetts, the exchange law was signed in April of '06. The first employee was hired in June. Many of us came on between June and October when the law required that our first exchange be up. And in Massachusetts, there are two exchanges. One is an exchange for subsidized coverage for individuals. The second is an exchange for unsubsidized coverage for individuals above a certain percentage of the federal poverty level and small businesses. Perhaps the most controversial and I would also argue significant element of the Massachusetts exchange is part of an individual mandate. So what the mandate in the state requires is that state residents of 18 and above must have health insurance. And they can either get it on their own, they can get it through their school or university, they can get it by remaining a dependent on their parents' insurance plan up until age 26, but they need to have coverage. So this was an element of controversy at the time, but it seems to have worked reasonably well, at least in that state. The uninsured level has reduced from 10.4% in 2006 to 1.9% in 2010. There's no 11 data in yet. But the 1.9%, as you probably can infer, is the lowest in the country, and I would argue that without the mandate, it would not be that low. Massachusetts does have a free care pool for indigent care and those that are uninsured. The implementation of health reform and the insurance exchange in the state has reduced the cost of that free care pool by 38%, or about $500 million. Cost trend for Medicaid health plans, which are the MCOs, the average cost trend since 2006 has been under the market average. It's at 4.7%. And in the unsubsidized or commercial exchange, it's running at 6 to 9%, which again is in line or lower than national averages. One of the elements that researchers have been somewhat surprised in is that health reform has actually become more popular with residents in the state. The longer it's in place, there is now a 68% approval rating, and 220,000 individuals purchase insurance through the exchange at present. The big fundamental issue for the state, as many of you may have read and know, is controlling health care costs. It's not an issue that's loaned to Massachusetts. Costs in the state are about 17% above national average. It's become a employment issue as well as a political issue, and the state is now considering several options, including the initiation of global reimbursement to providers as some ways to address this issue. Utah represents a different approach to establishing an exchange. Their uninsured rate is at 14%, pretty much remained unchanged since the exchange was introduced in 2008. Instead of providing subsidized care for individuals with another exchange for unsubsidized care, the Utah exchange is essentially an enrollment portal for small businesses exclusively. They have, since 2008, just under 4,000 enrollees in the plan, and at present the state is reviewing its options to provide an insurance exchange for subsidized and unsubsidized individuals to conform with the ACA. This next slide gives you just an overview of the home pages of the Massachusetts and Utah website. I wish I could tell you the URL of the Utah site, but you can certainly get that from Google. The URL for the Connector website is mahealthconnector.org, and you can see in the Massachusetts site that there are essentially 5 segments represented on the home page. There are individuals and families, young adults, employees, employers, and brokers. The young adults have a separate tab because in Massachusetts there is a separate set of benefits for young adults between 18 and 26. So with respect to best practices, and certainly I'm taking this from my experience both in the public sector at the connector and then back in the private sector with working with the private exchanges in California, that there are essentially some key elements that are applicable to both. One is the importance of a strategic and actionable communication and outreach plan. Insurance is not a particularly sexy purchase. It's not like buying a new car or an iPad. People don't like it. It's complicating. It's expensive. Using it doesn't feel like good news. So to be able to reach out to both existing and newly eligible individuals and small businesses, talking about the opportunities and obligations under health reform is something that is critical to establish a successful exchange. The second is the integration of the verification of insurance eligibility for state and federal subsidy programs. So one of the key elements of the ACA, matter of fact, it's in Section 1311, is the coordination of insurance subsidy programs in the exchange, in essence to make it as easy and simple as possible for eligible individuals and families to enroll in the appropriate program. And so the law and subsequent regulatory releases are trying to be as prescriptive as possible with ideas about how to make this occur. Not simple to do particularly, but the goal is to make it as easy and simple for the user as possible. The third is to have a simple to use but comprehensive information and enrollment portal. If any of you have the interest, I think looking at the Utah URL, looking at Healthcare.Gov, which is the federal portal, or the MA healthconnector.org connector portal, may give you some ideas of different approaches to try to get to that very end. The next is a empathetic call center. Our experience in Massachusetts showed that roughly 32% of purchasers wanted to spend between 20 and 30 minutes on the phone with a call center representative, walking through their options, understanding the benefit plans in front of them, and trying to get some objective advice about the right plan for themselves and their family. Again, because of complexity and expense, it's important to have representatives at the call center that are trained in a way that they can be empathetic, because this is a very challenging purchase. The next is enrollment training for navigators and for insurance brokers. Navigators are often community advocacy groups or consumer advocacy groups. One of the ways that we did this in Massachusetts and also in California is putting together a basic training program with a very simple type of knowledge validation test at the end to walk through the core elements of the obligations under health reform and the opportunities represented by the exchange. Brokers are particularly important to get to the small business segment. Navigators are particularly important to get to individuals. The next is the importance of supporting health plans. Insurance companies are key suppliers in the chain of the products. Our experience has been that when there are routine communication meetings with these firms, we typically recommend monthly meetings that the health plans feel very much more integrated into the issues being debated in the exchange. Their input about how to make the exchange more effective is critically important for its success, and it just overall builds a level of trust which helps make the mutual interest of both the exchange, policymakers, the advocates, and the health plans at the forefront. So I guess the key message here is that one can't over-communicate to the key suppliers of coverage. And finally, once again, focusing on easy and simple. If that's one bit of advice, and I've been to about 38 states so far, that I give to the states is just focus on those three words. Easy and simple for the user, as easy and simple for the health plans as possible, as easy and simple for the state regulators. Just try to make a complex issue uncomplicated. Not easy to do, but a worthy goal. Thank you.
Thank you very much, Kevin. I'm going to turn it over to Mark Lutz. Mark?
Thanks. And Kevin, enjoyed your presentation, and you obviously have a wealth of experience that the nascent exchanges around the country can benefit from. If we would advance the slide here, I'll go ahead and do that. As we approach the 2014 time frame, there is a huge amount that is yet to be answered in this category. We all see this goal, which is why we came up with this topic slide, the health exchange population. We all want to see success in attracting the uninsured or the underinsured into these exchanges, and we would all like to see them get affordable coverage through the exchanges, but there is much yet to be seen as to whether that dream can be realized, whether that public policy goal can be realized. The NPRMs that have come out from the feds to date don't lend much predictability, at least in my view, to whether this outcome will ultimately be successful or not. The NPRMs leave most of the decision-making to the states on a whole slew of vital components as to exchange operation and the shape of the individual and small group markets around the exchanges, which will heavily affect whether or not they're deemed to be ultimately successful. So one of the takeaways from this is that no matter what hat you're wearing in the audience today, whether you are part of the strategic planning process for a current participant in the individual or small group market as an insurer, whether you are a broker, whether you are an employer contemplating your options and the sound evolution of your employee health welfare benefits going forward, or whether you are a provider who is ultimately interested in seeing additional patients being covered when they show up on your doorstep. There is a strong need for involvement on your part in your state's effort or your region's effort to shape this mechanism and shape the dimensions of the individual and small group markets as they move forward. So the takeaway again is there's most of what is going to be vital in determining or driving success or lack of success is yet to be defined, and so you have a present opportunity to be a voice in that design, much as Kevin's being a voice in the matters that he has expertise in, to promote the success of these models. And from a public policy perspective, what we are hoping, and what PPACA or the ACA, depending on your preference of rubric of title, is driving at, is that we're hoping that we not only have additional coverage options available, but those coverage options are ultimately cost effective so that they can be maintained going forward, and there's attraction to the new marketplaces that are developed. So the ACA and PPACA want to, on this slide, do at least 4 things, and these are the 4 things I'll try to briefly touch on, what we know about how they're emerging so far and what we'll continue to need to watch. We want to attract the uninsured population into these vehicles. Secondly, we want to, or the law wants, the uninsured population to have a wide choice of plans available to them. And thirdly, the law would like to see that the populations that become covered under these plans are managed cost effectively, and that their care is managed across care settings, and the populations end up being managed across their temporal dimensions if they go on and off of in exchange coverage, most notably whether they cycle in and out of the exchanges and Medicaid. And Rule 4 is keep the plans affordable, which is inevitably linked very closely to whether or not the uninsured population will be attracted to the exchanges and remain within those vehicles. So let's start with that goal, attraction of the uninsured population. There are 2 mechanisms within this public policy construct that could drive, or they can drive together. They can work synergistically. One would be the individual mandate, and the other is pricing. On the individual mandate side, we all are watching with interest as to whether or not the individual mandate survives the judicial challenge, or whether in advance of that to revise it and create other motivators for participation. But we can be a little bit myopic if we focus all of our attention on individual mandate for a number of reasons. One, the small group participation in the exchange world is not being driven, or would not be driven, by individual mandate. And secondly, probably at the end of the day, the individual mandate is not set at a high enough level to overcome other reluctance that folks in that band might have to participation. So it will come down to attractive pricing for the product. And the exchanges, in theory here, will be bringing, or actually in actuality, a community-rated product to more broadly than it is currently available to the individual market. That's a state-by-state determination at this point. The ACA is bringing to the table as well regulation of insurance rates with a federal backstop to that regulation in a way that we've never had that before. And lastly, for a certain portion of the population, there'll be subsidies available to support individual purchasing. So there are a variety of levers here being applied on the pricing side, which could lead to effective movement of this population into these vehicles if some of the unknowns break the right way. As Kevin indicated, there is a unanswered question as to the richness of the essential benefits package. I think the IOM study reflects a recognition by some policymakers that there's a tension here. You can go overboard in prescribing essential benefits and have an impact on the price at which the package can be offered, and that pricing could be so high that the package being offered through the exchange while it may be administratively easy to access the package, none of them might be attractive from a price perspective if the essential benefits are defined too richly. Plan competition obviously is going to vary on a state-by-state basis, but beyond the immediate elements of plan competition, as we know it traditionally in the individual and small group markets, we have to be assessing whether this vehicle will bring new actors and new marketing alliances into these markets. If those of us who are around for the advent of Part D will remember new marketing partners that emerged as when Part D came on the scene and changed the dynamic of many things at that point, that will undoubtedly be in play to some degree here as well, although the market opportunities will be much more fragmented than it was in the Part D during the Part D experience. The other question that this slide asks you to think about going forward is whether or not the exchanges will take an active to watch, and to the extent you have an interest in the outcome of this, to be a participant in the public policy debate as to whether or not the exchanges become an active shaper of delivery system finance and potential value-based purchasing deals between the risk bearers and the care deliverers for this market going forward. It's widely acknowledged that some of those that will be participating in this market will have complex and chronic conditions for which a traditional indemnity benefit design is not optimal, that more active care management is the best way to control price trend going forward, and therefore there is an interesting opportunity here for the exchanges to begin to potentially encourage insurers in one manner or another to increase the amount of value-based purchasing they do from the provider community. That debate is being played out, as Kevin indicated, now in Massachusetts. It's likely to be on the table elsewhere as well over time. The second goal from a public policy perspective is that those that are attracted into the risk pools should have a choice of plans. The NPRM has given us a begin. Again, it's a proposed rule, but we can see some very thoughtful attempts. And then everybody knows that public policy tends to be most successful if it's evolutionary. We're unlikely to get it right, the mix right in the first place, but there is a framework. There's a lot of thought being given to reinsurance and risk corridors and risk adjustment to address some of the adverse selection challenges that risk pools have suffered from in prior attempts at exchanges at the state level. And again, from a competition perspective, the NPRMs have given states quite a bit of running room in this regard, and as you've probably read, their approaches, and as Kevin has indicated, their approaches can be all over the map on this, from a theory that they, in order to get adequate sized risk pools, will severely limit the number of participants, to a theory that sort of an any willing insurer type theory as being the appropriate way to approach things. Population health management will in the end be a material driver of the success of these of the program, and again, to the extent that you can be involved at your state level in this issue, that would be important. There will, Kevin, perhaps in the questioning period, can address some of the phenomena that Massachusetts experienced relative to pent-up demand. We have reference here to the realization that for many participants in this risk pool, there will be a variety of drivers of medical services, not all of which are simply medical. There will be social. There could be mental health and substance abuse issues for the population, and so ultimately success in the area will be determined in part by whether or not the exchanges allow and encourage the development and sale of products and delivery system solutions that address these complex social needs. This slide also touches on that there is an opportunity and at this juncture for exchanges to actively foster plan designs and to potentially make as a requirement of participation the incorporation of innovative payment arrangements between healthcare insurance issuers in this space and providers. That is that's within the scope envisioned by Congress in the ACA or PPACA. How many states ultimately take up that gauntlet to drive delivery system change through this mechanism is an unknown at this point, but will be, I'm positing, highly significant in terms of whether or not these populations can be managed effectively, cost-effectively going forward, and ultimately whether the exchange risk pools are viable will depend on whether the gauntlet is picked up on some of these challenges, particularly given and there's much important work right now being done on analyzing the population overlaps between particularly an expanded eligibility for Medicaid and exchange-based population on a seasonality basis, et cetera. That is worth the strong consideration by any on the phone who are in a policy-making role, and certainly any on the phone that are tuning up their health plans to address this population. There'll be arguments to be made that the most effective products put forward will be seamless with Medicaid programs, managed care participation in Medicaid, and that the investment that it will be necessary to manage the population will be significant, and that so those that it will not be a casual participation option for plans that choose to be involved here. The other dynamic that exists is that not every state is going to, for political reasons, step to the plate at this juncture and try to define the exchange dimensions and market dimensions that we've been talking about. A large number of them may default, or some material number of them may default to federal regulation and federal definition, and we've yet to see how the federal government will approach defining exchanges. There's part of the exchange market that will be within its ambit. We all hear about very large numbers being potentially associated with this market opportunity. CBO saying 24 million. I think Deloitte recently putting a number running between 23 and someplace in the 60s million. But as a practical matter, those numbers are going to be heavily affected by how much participation we get through different market segments, and the market segments are quite different. The individual market is very different from the small group market in the 1 to 50 range. There are incentives at work there which are different from the mid-sized employer market, and so any analytic of the opportunity here needs to do some segmentation in that regard. So in this last slide, and then I know that we're looking forward to your questions, tries to depict graphically a little bit some of the algorithm, the opportunity algorithm that may be at work here for those of you participating on this call who have strategic planning responsibilities for your organization. The first bullet, or the first circle there, where we're asking the questions that these slides have asked about: to what degree will the offerings themselves attract people to this vehicle? Will we have a mandate that is relevant to the individual market or not? We would add to that everything that Kevin has had to say about the effectiveness of the exchange that is set up in its communication, its integration of subsidies, its consumer-facing attributes relative to call center, et cetera. The choices here, or the variables here, are many. I think at the end of the day, those plans that are thinking about the degree to which they want to concentrate in this market will be challenged to analyze the opportunity not as a national opportunity, because each of these exchanges are likely to be quite different, and the investment necessary to access the market or to play in each of those markets will be different. The populations that are ultimately within that market opportunity in that geography are likely to be different depending on some of the choices made that we've identified. Obviously, added to that needs to be a competitor analysis, and in the final analysis, this exchange opportunity has to be evaluated within the construct of your portfolio strategy. Each plan is going to approach their portfolio going forward slightly differently, depending on whether they traditionally or want to remain individual market focused, small group, mid-market. Attractiveness of or the changes in those markets will differ quite significantly, and so the plan's opportunity ultimately ties back which of those segments it sees itself playing effectively in going forward.
Okay, Mark, thank you very much for that very informative presentation. We're going to move to the question-answer session right now. We have several questions from the audience. The first one, I think, was clarified before, but I just want to go over it, is essentially the difference between the acronym ACA and PPACA. I don't know if either of you gentlemen want to clarify that again.
Yeah, Simply said, they're the same, one and the same. Some people will go by the protracted name of Patient Protection Affordable Care Act. Some will just call it the Affordable Care Act.
I apologize for any confusion by that. This is just clearly an example of someone that's been doing this too long.
Okay. So the next question, this is directed to Kevin. What are the roles and opportunities for insurance brokers in terms of interfacing with the exchanges?
The roles and opportunities are in my experience, are pretty extensive. Brokers act as trusted advisors in the procurement of insurance for many individuals and in particular for small businesses. Because of the complexity and expense, as well as the regulatory requirements of employer-sponsored insurance, employers and often individuals typically rely on brokers to help them pre-screen eligible coverage, carriers, price comparisons, and other types of features before a buying decision is made. Because of the potential for expansion of the insured pool, which was just previously discussed, and again, based on my limited, my 5 years at the connector, I would tell you that I think the opportunities for brokers are significant. I know some brokers view the exchanges as a competitive threat. I think there's a segment of brokers for whom it's almost impossible to get them over that idea. There are others that see it as an opportunity to enhance their distribution channel and look at the exchange as another market opportunity. So, in summary, I think there's significant opportunity for brokers in the state exchanges.
Mark, I'll just jump in on that just a second, because Kevin, and the question reaches a very important point. When you're looking at the potential success of exchanges in attracting small groups, that is going to be closely bound up with the question of how effectively an individual state exchange incorporates a ongoing role for brokers, in my opinion, because the small group, by and large, it's heavily dependent on its broker for basically the HR function, the benefits function, and the challenges that have existed. Even, and Kevin would love to hear more about it, but I understand anecdotally, the SHOP enrollment in Massachusetts relative to the individual enrollment has been pretty small, I think, historically, and I think you were working overtime to get out kinks in your broker relationships to address that. I think that's just a lesson as this gets rolled out, that we can't expect exchanges to do everything that small groups expect and need in order to continue to provide these benefits, and so an effective integration with the brokerage community is likely to be a success factor.
Yeah, Mark, I couldn't agree with you more. I think just to provide a brief context for a comment you just made, the SHOP experience in Massachusetts, I think there's often, I think, sort of a misunderstanding of what that was. That was a pilot program with 20 brokers that could only sell the SHOP plan to their existing clients. It was never opened up to the marketplace. It was done to test the operational capability. That being said, I would tell you that I agree that, at least in Massachusetts, I think that the evaluation of SHOP would say that it had limited market appeal. Two was that there was complexity in administration and in explanation to both employers and employees. And three is that, unlike some of the predictions made by some of the health plans, there were not examples of adverse selection. we had a consulting panel of actuaries from all the health plans to review that data. So that's just to provide a bit more context.
We have a follow-up on that, which is basically I wonder if either one of you could explain how a broker would get paid in an exchange situation.
Let me just, and I appreciate Mark's view on this as well. I think there's really two options to that. One is the broker would be paid by the exchange directly, and the second would be that the exchange delegates that to the respective health plan. In Massachusetts, the exchange paid the brokers for a bunch of different reasons, particularly budgetary. We could not afford to pay at the same rate that the health plans did. We were about a point less than the health plans, which is not insignificant. But those are fundamentally the two options.
Mark, do you want to expand on
that?
that?
I think Kevin captured it well.
Okay. Our next question is, there's been a lot of discussion on the state level regarding transparency and movement within the exchanges, but what's occurring or what's being put into place across the states? I guess that would be in reference to a federal level exchange.
And to help me with this, I'm not sure that I quite comprehend the question. If transparency and movement within a state is the ease of disenrollment in one option and enrollment in another option, I guess I understand that. I'm not aware of federal efforts to, and maybe I'm not understanding that.
Well, actually, I think re-examining that question again is what's being done in terms of, I would presume, if you're moving from one state to another, would you be able to keep your coverage, or how would that work, or has that not been figured out yet?
So this is the portability issue?
Yes, based on the way the question has been phrased, I would imagine that yes, it does address portability.
Yeah, I'm not a, Kevin.
So yeah, sure. So if I understand the question properly, and please, Mark, jump in if I've got this messed up. If someone were insured in say in Texas, and then moved to Colorado, because there is no more underwriting requirements and there is guaranteed issue, that individual moving to Colorado would then be eligible for the available health plans in Colorado. They would not be asking for pre-existing condition information. Again, the plans would be guaranteed issue and guaranteed renewability. They wouldn't, if they were with a national health plan, for example, an Aetna, Cigna, United, for example, they may be able to take the same plan, the same carrier, but not necessarily the same plan of benefits. If a different set of plan of benefits were approved by the Division of Insurance in that new state.
Okay. Yeah, I wouldn't. I would agree 100% with that analysis. There isn't anything, as Kevin ended up saying there isn't anything that is here though has changed the fundamental nature of state plan of benefits, and therefore there's a possibility that what you had in Texas might not be exactly the same as what you get in Colorado.
Okay. Next question. This is regarding what Kevin had said in his presentation regarding having an empathetic staff. Would you be able to have a staff to be able to help with customers that would? I mean, does the law require that it has to be within the United States, or is this something that could be done with an offshore staff, perhaps India or the Philippines, or is that something that you have concerns about that wouldn't necessarily work?
That's a great question. I have not had that one surface before. And Mark, help me on this. I don't believe there's anything in the ACA that dictates geographic location of the staff. I would tell you that politically, I would find it highly unlikely that a state exchange is going to provide offshore customer service.
Mark, do you want to contribute anything to
I would agree. Nothing in NPRM or ACA that would constrain it, but overtly. But from a practical perspective, I think Kevin makes a good point.
And in terms of empathetic staff, are we talking about college level people with college degrees able to help out, or just people with very, very highly evolved customer service skills?
You know, it just, again, this is a sample size of one, so you have to be careful about what to extract. But it's more about how they're trained. It's more about sensitivity training around the types of behavior segments that are that could be using the call center. And my point around the empathy is that this is a frightening purchase to a number of people. 2 years ago was the first time that the average family health insurance plan in Massachusetts is more than the average family mortgage. So when you're dealing with numbers like that, also trending up 9% a year, people want to make sure that they're making the best decision that they can. And the customer service reps that are given the training to understand the dynamics of the type of people that are calling, what their issues are, what their fears and concerns can be, and how through certain behavior they can help calm some of those fears, that results in a much more satisfying user experience.
And another just point to add on that, and then I'd ask Kevin to help us think further about it, and that would be there is a large amount of definition left to the states in this regard, because you could have the state exchange just being a portal with some degree of price comparison information being made available, but essentially the potential customer being passed off to a participating health plan's website and service functions, even at the enrollment, even relative to the enrollment part of the customer experience. Others could try to perform greater levels of or assume greater levels of the sales process, more functionality involved in the sales, and then also, but it's also within the ambit of the question and where our discussion's going, is there's also an opportunity for ongoing member management type services beyond initial enrollment and billing maintenance type things. And again, you've got a public policy determination to be made as to how much of that you try to centralize versus hand off to participating plans.
Yeah, I think that's a really good point. I mean, it's not uncommon for states to have their own call centers for Medicaid enrollment. And I know some states are thinking of simply enhancing or retooling those existing call centers to handle the exchange population as well. But Mark's right. There is the option for using health plan call centers, and states will do different things.
Thank you very much.